Good morning.
Good morning. Sorry I couldn't come even sooner. I
That's
just
okay.
finished my
No,
last.
we think Dr. Tisnick might have been called into clinic, so no problem. All right, thanks guys for hanging with us. I appreciate you being so patient. So we're going to move to our first speaker. So Dr. Jeremy Yee is a senior physical therapist. He's at Shriners Children's Northern California. His credentials include Doctor of Physical Therapy. He's a board certified pediatric clinical specialist and a certified neuro specialist. So welcome, Dr. Yee.
Thank you. So I know there are some template kind of some questions I can go over. So I'll start with that and then open it up to Q&A afterwards. Can everyone hear me fine? Okay, awesome. So right now I currently work at Shriners Children's Hospital. It's a pediatric hospital with various settings of uh, lots of different medical professionals, but within physical therapy, we treat patients that are inpatient, that are currently staying in the hospital. We treat patients outpatient that come in for scheduled physical therapy appointments. And then we have an intensive inpatient rehab unit where we also treat patients with all sorts of neurologic deficits, such as spinal cord injury, brain injury, and more severe polyorthopedic trauma. So that just gives like a little um, sense of the types of patients we treat here. But that said, I'm going to backtrack a little bit. So my day to day of a physical therapist can look like going in, you start your day, do you have a set list of patients that you might see for the day, whether you're treating mostly inpatients or outpatients, and then spending the first maybe 30 minutes to an hour chart reviewing and taking a look at the different patients' medical history. If they've been treated by physical therapy here already, then we can take a look at the patient's what they've been working on in PT and the overall plan and the goals that we're working towards, and then spend the rest of the day treating patients. And then afterwards, just really being able to take the time to document. And this is probably the least fun part of the job is spending time at the computer, but we do have to document and justify why we're treating patients and how we're progressing them towards their goals. That way that insurances can cover our services. And then that's pretty much a typical PT's role in the hospital. If they're inpatient, then they would have more communication with the doctors, nursing staff, occupational therapists, speech therapists, all sorts of different medical providers that we have in the hospital, and then also be able to coordinate the different uh, treatment plans. And sometimes the plans overlap, sometimes they don't, and then we just do the best we can to treat the patients and do what they need to meet their goals. Um, there's a question about how do you interact with patients, and pretty much in physical therapy, probably 80% of the opportunities out there in the world are hands-on. So you're really working with the patients, whether it's in the inpatient setting, trying to help them get up out of bed, stand and walk, or get into a wheelchair. If it's outpatient, you might work with a patient after a surgery, such as like a hip or knee procedure, or anything in the lower body or upper body, but helping them regain their function, whether that's a return to sports or being able to get back to work. There's lots of different opportunities out there in the outpatient world to focus on what the patient or the client needs to be able to do to get back to their daily life. And most of the time, it is very hands-on, which is an amazing part of our career. We get to really be directly involved, and a lot of it is also planning with the patients, families, how what is realistic to them. We can't just give a set of exercises and expect the person to do what we tell them. We really want to collaborate with them and make sure that they're able to realistically do what we set out for them, and then have them part of our treatment plan. Um, there are the options instead of in-person direct physical therapy. There's telehealth. So you might have heard this from other speakers, but there's more virtual physical therapy opportunities. And that's where you're in front of a screen, kind of like we are right now. And then seeing live what the patient is able to do. And then we give them feedback and instructions on how to do an exercise safely or how to do a certain movement correctly. I don't personally have experience with that because here at Shriners, we don't offer telehealth services, but that is another opportunity to interact with patients in the physical therapy. Thank you for your question, Sam. There's definitely a difference between occupational and physical therapy. And sorry in advance, I let the other coordinator know that our senior occupational therapy, um, our senior occupational therapist, her name is Jessica Kager. Unfortunately, she isn't able to make it. She's out of office right now, but she was going to talk about occupational therapy. I feel like a lot of people know more about physical therapy. That's advertised a lot more. Physical therapy is really focused on movement and mobility, whether that is, like I mentioned earlier, being able to return to work, being able to focus on standing, walking, big mobility tasks. A lot of times we think about return to sports, whereas occupational therapy might focus early on in the inpatient setting on activities of daily living. What are the basic tasks that you might have to be able to do to live? What is that? Bathing, dressing, taking a shower, brushing your teeth, getting dressed, and being able to do those simple tasks that a lot of us take for granted. And then whereas physical therapy, we're going to be focusing on balance and mobility and being able to do the bigger movements. Um, there are opportunities in occupational therapy in the outpatient setting to focus less on what we would consider those activities of daily living, but think about return to work as well. In a lot of environments like Shriners, the occupational therapist might work on fine motor skills and using your hands, whereas in physical therapy, we might focus a lot more on leg strength and mobility, um, and thinking about walking and doing things more with your legs. But the cool thing is that occupational and physical therapy do overlap a lot. So here in Shriners, we're able to do a lot of co-treatments of PT and OT. And depending on the patient's abilities, whether they're little 2-year-olds, I treated a little one today, trying to just learn how to crawl or stand up from the floor and play. A lot of times the OT and PT skills do overlap. So we might work on very similar tasks, but for different functional goals. And then also someone that is just learning how to stand and can't put their own shoes and clothes on. The occupational therapist might have to work on the patient being able to sit and balance and have a strong core in order to do those tasks. So the cool thing is that we do overlap a lot, but then there are definitely different goals that we're working towards. Now I'm going to backtrack a little bit even more and talk about the educational and career journeys. For physical therapy and occupational therapy, in order to become a licensed physical therapist or a licensed occupational therapist, You do have to get your bachelor's degree. So that could look like a 4-year college and obtain your bachelor's degree. Sometimes it might take longer, sometimes it might take shorter, but on average, about 4 to 5 years. That could be at whether a state university or a University of California. Um, Oftentimes, there's the routes that you can take, including going to a community college, a junior college, and then transferring to a 4-year university. We hear it all, but once you get your bachelor's degree, you can apply for this graduate program, whether it's occupational therapy or physical therapy. Both programs are graduate programs, and on average, occupational therapy could be 2 to 3 years, and then physical therapy is usually about 3 years after your undergrad. Um, in the past, physical therapy and occupational therapy used to be master's programs, but most occupational therapy programs have transitioned to a doctorate program, and physical therapy programs all throughout California, especially, have all been transitioned to doctorate programs. So that just means more schooling, more research involved, and yeah, just more education. So on average, about 3 years of a program after undergrad. Um, and then along with school, once you graduate as a physical or occupational therapist, there's the opportunities to advance your career and get specialty certifications. Um, Similar to like medical school, there's post graduate programs such as residencies. So for PT and OT, there are residencies that you can take for another year or longer to get a special certification. And then there are options to specialize in pediatrics, geriatrics, uh, orthopedic, sports, neurology. There's quite a few different specialties that you can um, go into. My path was a little different. After I graduated from um, physical therapy school, I became a licensed general PT. And instead of doing a residency, I actually went and studied on my own and worked for a few years. And then I applied for my pediatric clinical specialty. And that's a board certified specialty that I had to take a long test for. But it all paid off, and I was able to get that certification. So there's different paths that you can take to become specialized in different fields. And then just a little bit more about the profession of occupational and physical therapy. There are so many different other options out there, in addition to just being a licensed OT or PT. There's certified occupational therapy assistant programs and physical therapy assistant programs. Those programs don't generally require undergraduate or a bachelor's degree. You could just take some courses, prerequisite courses, and then apply for these certification programs. And those generally could be about 2 years. So although you wouldn't be able to evaluate and oversee a patient as a licensed PT or OT, you could be an assistant and still treat patients under the supervision and guidance of a PT or OT if you wanted to be that OT assistant or PT assistant. There's also lots of paths you can take in the profession in terms of teaching, being a professor, going into research, treating patients in their homes, which is considered home health, working for a team in sports. The really cool thing about both OT and PT is that there's a lot of opportunities out there. And then the last thing I'll say before opening up to questions is that if I can give any advice to any of you pursuing healthcare, I'd say definitely just try to get your feet wet and um, take advantage of any opportunities there might be to shadow a PT or OT or any healthcare professional before committing yourself to it. I've heard a lot of stories of people going into medicine or physical or occupational therapy without much experience, and once they start their schooling, um, they might backtrack and drop out of schools, and then decide that maybe another healthcare profession is more suited for them, and that is okay. But also, you could also get get that experience earlier on and really make sure you're interested in a certain path as well, if you can get any volunteer work or internships beforehand. I feel like I talked a whole lot. So now I'll look at the chat to see, look at some questions. The next question I see is, what's the hardest part of your job? Um, I have two answers. One is not as related to everyone. I work as the senior physical therapist at Shriners, so I oversee all of the physical therapists and have more of a coordinator role where I treat patients, but also am in charge of assigning patients and delegating tasks to the remainder of the physical therapists. So sometimes the hardest part of my job is just um, making sure that everyone is working cohesively as a team and not upsetting people. You'll find, if in the future, if you take on leadership roles, you're it's never possible to not upset someone or make feel someone uh yeah, like it might be as long as you're treating someone fairly, whether it's a patient, client, or your team member. I think open communication and making sure everyone is treated fairly is really important. But sometimes it is uh, necessary to assign tasks that are important, but able to provide, uh, as long as we're able to provide patients and families the care that they are needing, that is the ultimate goal. So sometimes um, some people might not take it the best way in terms of delegating tasks as a more of a lead role, but we do the best we can for our patients and their families. So to me, that's my current like toughest position, because I still feel like I'm young as a physical therapist. I've been working at Shriners for 7 years now, but especially if I have to delegate tasks and make sure that our patient care needs are being taken care of, that could be sometimes tough. And then overall, as a physical therapist, I think another difficult part of the job is uh, in pediatrics, dealing with multiple family members or other input from other people that are visiting the hospital. So I'd say working at Shriners, it's so easy to me, at least to me. I've gotten used to working with the kids and getting kids to participate in their therapies, but sometimes it could be a little bit challenging when there's different expectations between the kids and their parents or other extended family that might have a say in, who definitely have a say in the patient's treatment plan and goals. But sometimes it can be challenging to please everybody, and just making sure that we communicate with the patient and the family what the goals are and that everyone's on the same page and doing what's best for that kid or teenager. That's what's most important. So sometimes having difficult conversations with family members can be challenging. There's another question. What made you pick this career? So going back to what my advice was earlier in terms of volunteering and getting internships, I I knew that always wanted to go into healthcare, and probably before uh, going into college, I went to UC Davis for my undergrad. Before starting there, I knew I wanted to be in healthcare. I loved working with animals. I thought I was going to be a veterinarian, but that didn't pan out how I had thought. And then once I started my college career at UC Davis, there were definitely some volunteer and internship opportunities that I applied for and was able to spend time individually with physical therapists at UC Davis. And then also there's a volunteer opportunity at Shriners. I took some internship opportunities in physical therapy as well as chiropractic and nursing, just to kind of get my feet wet and figure out what career seemed interesting to me. And then ultimately, I really loved being able to work hands on with patients, see where they are at evaluation, figuring out what challenges they have, and then being able to be a part of their treatment plan and really progress someone back to whatever it is that they are hoping to do. Their goals might be getting back to walking, being independent with being able to do um, getting around in a wheelchair or getting back to being able to play for fun, going back to work. Those are definitely things that I love being a part of their plan. So I think that was my favorite part of this career and made me want to pursue physical therapy. That's all the questions I see in the chat.
Jillian had a hand up.
Yeah,
Hi, okay. I was wondering, what's your work-life balance like?
that's a great question. And I highly recommend everyone, whoever, once you start work, you have to figure out that work-life balance or else you may burn out. So I have a scheduled work shift of 7:30 to 4, 7:30 a.m. to 4 o'clock in the afternoon. So I have to physically clock in and out. There are some other careers within physical therapy that you might be salaried or have different schedules. But for me, I try to leave work at work and not message my coworkers unless it's for fun reasons. Or I try not to have any work conversations when I'm at home. So I'll usually go home, and now I live at home with my wife and cat. So I like to just spend as much time with them after work, whether that's going on little walks or yeah, just spend time on Netflix watching my reality TV shows, or on the weekends, I like to go to the gym, play basketball, do outdoor active activities like hiking. So it's really a matter of just shutting off work once I leave the office and prioritizing my time with my family and myself um, outside of work. Does that answer your question?
Yes, thank
You're welcome. There's
We have
another
another,
question.
yeah, in the chat.
How much of your workday is spent directly with patients? So every workplace is different in terms of their productivity expectations. And we call it productivity because we are billing for every patient care encounter that we have. So for every session, if we spend about 40 minutes for one session, we have to bill that amount of time to make sure that if insurances do pay, that they do reimburse the hospital or the facility for our time. At Shriners, our expectation is to see a 50% productivity, which means if I'm working an 8-hour day, which I do, I'm expected to see patients directly for 4 hours. And then I still have another 4 hours in my day to chart review, document, gather materials if I need to, uh, talk to my colleagues and be able to collaborate on maybe there's a super interesting case or a patient that we want to talk about. So that is time not spent directly with the patient, but there's learning opportunities, there's different opportunities to get trainings, and then also all that not very fun time of spending in time documenting at our computer. But yeah, that's how our process is at Shriners. We have about 50% of our time devoted to patient care, 50% of our time for free time slash documenting. The next question is, do you have any advice for standing out on internships or shadowing applications? My advice would be take advantage of your opportunity and really ask questions and try to have as much direct patient care or direct patient involvement as possible. So many internships and shadowing opportunities, including at Shriners, involve cleaning, helping the therapists organize, whether that's putting away toys and games and equipment before or after a session, helping to sanitize equipment, making sure that no one gets sick and that we follow appropriate hygiene protocols. But there's also lots of opportunities to observe, ask questions to the patients and families, and then also before or after sessions, asking the therapists questions. Even though you might feel like you shouldn't feel like this, but you might feel like you're a burden or taking time away from staff for the patients. As long as the staff member is okay with it, most of us are more than happy to teach, educate, and pretty much give you advice. So you will definitely stand out if you ask questions. Maybe don't ask like tedious questions or repeat questions like all the time, but I always like to think there's no such thing as a dumb question. So if you have a question, just definitely ask in. The worst thing is that it might not be at an appropriate time, or you might be the staff member might say that they don't have an answer to that question, but it's always good to ask and also take initiative, because once you get yourself more involved and ask if there's things that you could do more, then staff will be more willing to give you more tasks or be able to help you out a little bit more. Are there any other questions?
Does anyone have any more questions for Dr. Yee?
I will say, if you are interested in volunteering at Shriners, I am also in charge of the volunteer program for our physical and occupational therapy department. So if you Google Shriners Children's Northern California and volunteer opportunities, you'll probably be able to find it. But yeah, there's definitely opportunities out there to volunteer. You do have to be 18 years old, though, at least in order to apply. Sam, do you think we have time for this next question?
Yeah, we have time. Yeah.
Okay. So why did you choose to specialize in pediatrics? Also, in addition to wanting to work in healthcare, I always loved working with kids. I had a background in coaching and refereeing youth basketball. And also, I just really like kids. So when I started volunteering at Shriners during my undergrad in the physical therapy department, and then also when I was in physical therapy school, there were assigned internships, and that's where you're a student physical therapist, and I was able to pretty much practice physical therapy under a supervising physical therapist. And usually all PT programs and OT programs will give you some length of 8 to 12 week internships, maybe 2 or 3 of those throughout your schooling. But I just really loved working with kids. And to me, pediatrics is so much fun because instead of giving a patient a routine set of exercises like 10 clamshells or standing squats. For the kids, it's all fun and games. So a kid is not going to want to just do a bunch of exercises unless they are a little bit more mature and can follow directions. Most of the kids love to play games and have fun. So we're often tossing a ball, playing on the floor, playing games like Uno. Is it Uno or Spotted are fun card games that kids love to play, or yeah, sometimes we incorporate board games and just more catch and play activities. So to me, it makes my job feel like I'm having fun and playing with kids instead of uh, like feeling like I'm working all day.
All right. Well, thank you so much for jumping on and sharing your specialty with us. We really appreciate your time. Everyone, please thank Dr. Yee,
Mhm.
and we hope you have a wonderful rest of your day. Thank you.
All right, you're very welcome, and good luck with everyone with your future careers.
All right, we're going to move to our next speaker. So Dr. Christina Ballou is a psychiatrist and chief of mental health services for Kaiser Permanente North Valley. She's also the president-elect of SSVMS, the medical society here putting on the program. And she's also the associate program director for the Greater Sacramento Valley Psychiatry Residency Program. So welcome, Dr. Ballou.
Thanks, Sam. So I'm not chief anymore.
Oh.
Um, I told Brandon that we had to update that, but so I'm super excited to be with you all here today. Thank you for spending some time with me, and just I hope that thus far you all are enjoying the Future of Medicine program. It's a great program, and um, very much in support. So I just wanted to take a couple of minutes. I'll tell you a little bit of my story, how I got into medicine, kind of what my day-to-day looks like. It looks very different from when I first started. And then ask any questions that you might have along the way. Just, yeah, feel free to just pop them in the chat. Or is there, I'm not a Zoom person. Is there a raise your hand function on
There
Zoom?
is,
Okay.
yes. So we have a few that have raised their hand, but we'll also put them in the chat.
Okay, awesome. Perfect. So I I always knew I wanted to be a doctor. I don't really know where that came from. I My mom would tell me that, even like as a 3-year-old, I would say I wanted to be a doctor or a firefighter. I don't really know where the firefighter thing would have come from either, because I run away from danger. So but I I always wanted to be a doctor. I was very much into sports growing up, and it's how I connected with family. I played sports in high school, and so really thought I was going to go into sports medicine, you know, orthopedic surgery. I I in high school really tried to like do all the things that I could to set myself up for going into a career for medicine. So I uh, volunteered as a student athletic trainer. And so basically, I traveled with our athletic teams and did all the like taping and icing and learning and, all of the like gross anatomy labs. And I did all of the things to really try to set myself up for success. Um, and then I went to college. I went to Duke for my undergraduate degree, and college was hard. It was a lot harder than I thought it was going to be. And about halfway through college, I thought, well, maybe it's too hard. Like maybe medicine isn't for me because I don't know if I can hack it. So like this dream that I've had since I was 3, I was like 20, and like what am I gonna do? And my mom being my mom, I told her that I was gonna, change course, and I was gonna do something completely different. I wasn't gonna be a doctor. And she had some choice words for me. and and really just kind of sat me down and said, what's going on? And the long story short was I was struggling in school, and I didn't think that I had the capability to get into medical school or to become a doctor. And I really actually at that point didn't know what it took to get into med school, or, I knew I had to have good grades and I knew that I had to take the MCAT, but I didn't really know what any of that meant just yet. And so I finally, my going into my senior year of college, I finally sat down and talked to an advisor about, what does getting into medical school really look like? And so we devised a plan for me to do a post-baccalaureate program. So after I graduated from Duke, then I did another year and a half of just like core science classes that I needed to gain admittance to medical school. And the other thing that the advisor told me at that time was change your major. She said, change your major, do something that you like. This is, the latter half of your junior year, your senior year, and take classes that you really enjoy, like get the most out of your college experience. So I spent my senior year in college. There's a primate center at Duke University. So I spent my senior year playing with monkeys and like reading and like watching movies and critiquing those. And so I just really took what she said to heart and just enjoyed what I was learning, and how I could apply that, maybe to not only to my degree but in the future. So I went on and I did a post-baccalaureate program at the University of Miami in Miami, Florida. And that was a really good experience for me. It was much different than Duke. It was really just to see how people work together and being in a different environment was great. And then I was like, okay, I'm ready. I'm going to apply to med school and everything's going to be fine. Okay, so I did not get into med school the first time. So I applied. I took the MCAT. I don't even remember how I did on the MCAT. And I couldn't tell you, this was a very long time ago. This was 2001. So none of you were alive. So, but I took the MCAT, and I didn't do great, but I went ahead and I applied to med school, and I didn't get one interview, and I was devastated. And I thought, okay, this is definitely a for sure sign that I am not cut out for this career. This is not going to happen. And again, my mom, as I literally was on her bathroom floor in tears, she kind of just stood over me and was like, "What's your backup plan?" And I didn't have one. Like, this had been my dream again since I was 3, that I was going to be a doctor. And she said, "Well, I guess it's time that you get up off the floor and we figure this out." And so I um I took some time and I started working. I started working full time, and when I wasn't working full time, I was studying for the MCAT. So it was like work and study. And I took the MCAT again. It did much better, and I applied for med school again and got a handful of interviews, and I got waitlisted at one school. And I was like, if it doesn't happen this time, then I'm just, I got to figure something else out. And I was working for Starbucks at the time, and it was a good gig, and I was making decent money, and had moved into a management position. And I was like, this wouldn't be so bad, like it wouldn't be bad. And but 4th of July weekend in 2004, I got a phone call from the admissions department at the University of South Florida, which is in Tampa, Florida. And the admissions officer he said to me, "What are you doing this weekend?" And I said, "Well, it's the 4th of July, like a barbecue and going swimming. I don't know." And he said, "Well, don't do anything crazy because you're starting med school in 6 weeks." And so I just kind of stood there stunned. Um, and so I started med school 6 weeks later, and um, it was a bit of a surreal experience, but also wasn't the last time that I felt like I was out of my depth. And I was in med school. It was the first year of school, and again, test taking. And I'm a very visual learner. I'm a kinetic learner, so like I have to see things, touch things, to really understand them. And um, med school was a challenge in that respect. I think it's a little bit different now that, you know, as we've learned how people learn, it's gotten better. But I struggled my first 2 years of med school, and there were times where I was like, I don't belong here. I can't hack this. And I was very fortunate that I had people along the way that just really encouraged me to continue to keep going. So long story short, obviously I graduated from med school. And remember at the beginning I told you like I'm gonna be I was going to do some kind of like either surgery um, or sports medicine. And through the course of med school, you know, you have 2 years of classes where you're just like in the classroom for the most part. And then you have 2 years of clerkships where you're out like doing clinic, you're out in the hospital seeing patients, you're doing, you know, you're in the operating room doing surgeries and all the things. And what I realized was that while I really liked the immediacy of how quickly surgery could fix things, the lifestyle, in terms of like that work-life balance, was not what I had envisioned for my life. And so I got to the end of second year, so getting ready to go into third year for our clerkships. And I remember coming home to my husband and saying, I have no idea what I'm going to do with my life. And he just kind of he looked at me and he was like, "You're going to be a doctor." And I was like, "Yeah, duh, like I got that part, but like, what kind of doctor?" And I was like, "I don't want to be a surgeon anymore." And he was like, okay, well, you'll figure it out. And I, you know, my first rotation, so you do like either four to 8 week long rotations throughout those last 2 years of med school. And my first rotation for my third year was psychiatry, consult psychiatry, which is seeing those patients that have some type of mental health or behavioral health complaint that are admitted to a medical or surgical floor. So they've been admitted for some other reason, like maybe they have congestive heart failure or chronic kidney disease that needs to be treated, pneumonia, something, but they're also having some type of like mental health or behavioral health issue that needs to be addressed while they're admitted to the hospital. And so I was at the VA hospital in Tampa, Florida, and by the end of that first day, I knew that psychiatry was it for me. And I always tell people it felt like coming home, which kind of sounds a little weird, but I settled into it very easily. And so, you know, knowing that at the beginning of third year made the rest of my med school experience so much more pleasant. And I stayed in Tampa for my residency. So psychiatry residency is 4 years. So I I did 4 more years of uh, my psychiatry residency. And you do all different kinds of rotations, even during your residency. You obviously have a long outpatient year where you're just seeing patients in the clinics. You see patients on the inpatient psychiatric units where they've been admitted specifically to get treated for maybe a severe depression or suicidal thoughts, or if they're psychotic. You get do some child psychiatry. I did some forensic psychiatry, which was really interesting. And then and then I did a ton of consult psychiatry. So after I finished my residency, I went up to New York for a year and did a year-long fellowship, which is an extra year of training, specialized training, specifically in consultation liaison psychiatry. So I just every day, that's all I did was see patients in the emergency department and in the hospital, and it really taught me about the intersection between internal medicine and psychiatry and how deeply woven our mind and body is together. So I did that, and then I was in academic medicine for a couple of years in the Midwest before I remembered that I'm not built for the snow, and then my husband and I moved out to California in 2015, and I've been with Kaiser Permanente since that time. When I first started at Kaiser, so kind of looking at like the day to day, my full-time gig was, seeing patients in the emergency department uh, and on the hospital floor. So pretty much what I had done for my entire fellowship and during my first job as an attending. And I loved it. I enjoyed what I was doing, but I quickly also understood that um, there was only so much that I could do just as a physician, right? There were systemic things that I was seeing or systems that I felt like, maybe our patients weren't getting the best care and things needed to change a little bit. And it was challenging to get those things done, just as what we would say is a frontline physician. And my boss at the time approached me and said, I want to put you in a leadership position. And I said, no, no, thank you. I just want to be a doctor. And he was like, well, you also want to change all of these things. So you can either complain about making change, or you can be the one that's actually doing it. And so that started my leadership journey. And I eventually became chief of my department. And that was during COVID, so that was super fun. And then, it also expanded to not only having leadership roles within my job, but also actually then looking to how I could serve my community, which is how I got involved with SSVMS. And then since then, I'm still a psychiatrist. I still see patients about 50% of the time. But now I'm no longer, as I said at the beginning, I'm no longer chief of my department. And so now I am an assistant chief medical officer for our hospitals here in Sacramento and Roseville. So, just continuing to look at systems and how we can make sure that our patients are getting the absolute best care, and systems that are equitable, and also that our people, that our doctors, our nurses, our staff are working in an environment that supports them and really looks towards both their professional and their personal development. A little bit about me outside of work. I I love Disney. You could find me at Disneyland on any given weekend. Um, Not that often, but I do like to go a few times a year. I still love sports. I'm an avid 49ers fan, and of course I follow Duke basketball and a bunch of college football teams. So like sports are very near and dear to my heart. So right now I'm a little bit it's a bit of a drought. I'm not a huge baseball person. So, and basketball's over, hockey's over. So I'm just kind of waiting, watching the World Cup. So that helps. But that's a little bit about me and kind of how I got into this and what the day-to-day looks like, and happy to answer any questions that y'all might have.
We have a question in the chat.
Yeah. So what did you do during your forensic rotation in residency, and how did you I think it says how did you feel about it? So yeah, it was interesting. So forensic psychiatry can look like a lot of different things. Some of it is reviewing or interviewing patients before they have to go to court, especially if they're presenting like a defense for a crime that's not guilty by reason of insanity, or to make sure that they are able to stand trial. Um, And so that's a lot of what I was doing during my forensic rotation. We had a forensic fellowship at my residency, so I that's how I found out about it. It was kind of already built in, and so it was one of the choices that I had. Um, it made me realize that I was not built for that type of work, because there were some pretty dark things that I read about and were exposed to, and I just was not it's like that's not what I want to do in my day to day. But very, very interesting to see how people's minds work, um, both for the good and the not so good. And I tested that theory a little bit more actually when I was in New York. I worked at Rikers Island for about 6 months, and yeah, it solidified that forensic psychiatry was not my jam. So, oh, let's see. Out of all the conditions you treat, are there any that you find especially interesting to study or work with? So I like a good mystery. So if there is something that kind of it looks like psychiatry, it looks like um, like, oh, this is classic depression or classic psychosis, or but there's something that's just a little bit off about it, and I can figure out what that is. I those are the ones that I like to delve into. So there's a condition called NMDA receptor encephalitis or autoimmune encephalitis. And really, there's a book. The book is Brain on Fire by Susanna Cahalan. And there was a movie about it. The book is much better, but really just how it mimics psychiatric illness, but it's an autoimmune disorder. It's an infection in the brain that is manifesting itself to look a certain way. And so I've had a couple of those cases that I've seen in my career that I've been able to participate in and treat. And um, it's probably one of the most interesting things. So if it's a little bit of what we would call like a zebra, where it kind of looks like one thing, but it turns out to be another, those are the things that I find most interesting. Jillian, you've got your hand up.
Hi, doctor. So I was wondering, you did mention that like there were some very, I guess, like dark cases that you've had to deal with. And I don't know if you handle anything of that severity now, but if you do, like, how do you deal with that? Because I feel like that's pretty emotionally tolling.
Yeah, it's actually Sam mentioned earlier that I'm one of the associate program directors for our residency, and our residents started yesterday, and we just had this conversation yesterday just about how heavy this work can be. Medicine in general, it's definitely a privilege to be able to care for patients and to sit with them in some of their most vulnerable times, but psychiatry particularly, people are sharing things with you that maybe they've never shared with other people, or you're learning things about them, or you're having to care for people that maybe have done things that are really bad, and they they still need care. And so really, what I have done in my own personal journey, there's been a couple of things, like always making sure that I have someone, in my professional community that I can go to. So whether that's a mentor, a colleague, a trusted colleague, something like that. And the other piece is, you know, therapy is great because sometimes things are really, really heavy, and you need, as the professional, sometimes you need somebody else that can be objective and can reflect back with you the things that are true, and that can hold that space for you as well. But yeah, I think one of the ways that I've dealt with it is really just making sure that I have surrounded myself with with support and with people, and not carrying it just on my own. I think the other thing too is making sure that I have things outside of my job. My job is a part of who I am. It's not all that I am. It's what I do, but it doesn't. It just makes up one part of me. And so making sure that I have those things outside of work that bring me joy and that can kind of balance the scales, so to speak. What do you do if someone will not accept help? Yeah, that's a great question. And it's really challenging, and it's something that we see a lot. So we'll see people that maybe they don't want to take medications, or maybe they don't want to go to the level of care that you're recommending. And so that really depends on um, kind of what the situation is. So is this person an acute, like an immediate danger to themselves or others, or, is their behavior going to impede their ability to provide for their basic needs? So food, clothing, shelter. So if any of those three things are true, then we would put them what's called a 5150, which is an involuntary application for their evaluation to be admitted to an inpatient psychiatric hospital. And so that is one thing that we can do if it's to that severity. More often or not in the outpatient setting, it's about, and sometimes in the hospital too, it's about figuring out, like, why do they not want to accept help? Why don't they want to take meds? Is it because they have experienced side effects from the medications, or they've seen a TikTok about how bad the medications were, or and so really sometimes it's about dispelling myths or just having a conversation and really getting to the why. And what we try most to do is meet people where they're at. So, okay, so you don't want to take medications. What are the things that we can do? What are some like behaviors that we can change to help with how you're feeling with your depression? Or are there other things that you might find helpful? So really continuing to work with them as in a way that they will let you. Sometimes people they'll stop coming to their appointments, they'll stop presenting for treatment. And what you have to realize is that's not necessarily yours to own as the physician or as the healthcare provider. Yet you've really done what you can, and to equip them with the tools or let them know what resources are available. And sometimes that's all that you can do. Um, Kind of a similar question, but what do you do if someone is refusing to accept that they have a condition that you've diagnosed them with? This is an excellent question. So when I am diagnosing someone with a new diagnosis, whether that's a depression diagnosis, bipolar, autism, ADHD, whatever that may be, we always have a conversation about how does that land with you? How does that sit with you? Do you feel like that's accurate? Like, what pieces of this diagnosis feel like you and what pieces don't? And so we explore that a little bit more, because ultimately, if they don't accept their condition, it makes it much harder. It makes it much harder to treat. And what I will do if somebody's like, that's not me, I don't have that, you know, I don't care what your tests or your diagnostic abilities say, like I don't have that. Then we talk about the symptoms that they're having and how we can treat those outside of the context of um, a diagnosis. Because also remember that these are human beings sitting in front of you, that they're having symptoms, they're having difficulty, whatever that is. And so we treat what's sitting in front of us. We don't treat diagnoses, even though those can be kind of a guidepost for us and give us, okay, for if somebody has depression, then we give these type of medications or these type of treatments or this type of therapy. But again, we're treating the person that's sitting in front of us. So we really want to make sure that we're focused on them and not just this label that we've given them.
Anyone else have any questions? All right.
Oh.
Well, it looks like we have all of our questions answered. Thank you so much. We really appreciate your time. This is always an interesting topic, and not something that everyone thinks of when they think about different specialties. You know, they, like you said, they think of surgery and they think of, you know, all of these super hands-on ones, but this is a great one to cover. So, thank you for sharing your story, and we appreciate your time.
Of course. Thank you for having me. All right. Bye.
Bye-bye. All right. We're going to move to our last speaker of the day. So Shannon McPartland is the Senior Coroner Technician at the Sacramento County Coroner's Office. This is always one of my favorite topics because it's not something we normally think of in healthcare, but caring for folks after they have passed is part of caring for humans. So I want to pass it to Shannon to talk a little bit about her career at the Coroner's Office.
Thank you so much, Sam. Hi, everybody. So like Sam said, I am the Senior Coroner Technician at the Sacramento County Coroner's Office. Just a little background on what a coroner's office does. We determine cause and manner of death. So the people that pass away in the county, not everybody needs to come to the coroner's office. Some people have doctors that they see regularly. They have different medical diagnoses that can technically lead to death. So those people with like cancer diagnoses and things like that, they don't have to come here. Our facility is for those people who die, and it's really a question as to why. So the coroner's office is made up of a couple of departments. We have our investigations division, who they are the ones that go out and they investigate the death. So they determine, first of all, if it needs to come to us, if it needs to have an exam by our pathologists, what happened, what the story is, all of that. So they interview families, they look at the scene, they do all of that stuff. Then we have our pathology department, who are forensic pathologists who are responsible for doing the actual autopsies and determining cause of death. So that is the specific reason why somebody has passed away. So that would be like the blunt force trauma from, say, like a motor vehicle accident, or asphyxia from something like a drowning, something like that. So they would determine the specific cause of death. And then our division, our investigations division, then determines the manner of death, which is, there are 5 different manners. So you have natural, suicide, homicide, accident, and then undetermined. So anybody that comes in to our care, they start off, it's mostly a question, what happened? And then through the investigation and through the autopsy and through all of those things, we determine what the most likely reason for the cause of death is. Sometimes we aren't able to determine that, which is why we have the undetermined category. Sometimes it's just impossible to tell what happened. But for the most part, we go through and we investigate these deaths. So as a coroner technician, what my job is to assist all of those departments in everything that they need. So the CTs, we go to pick up decedents, whether that is from hospitals or scenes, anywhere that they are in the county. We then process those decedents to get them ready for autopsy. So that's getting all of the stats. So like height, weight, hair color, anything that they are wearing, like clothing, we document all of that. Any kind of property that they have on, we document that. A lot of times we will remove it and package it up for family. That's our responsibility. We then assist the forensic pathologist with the autopsy. We are allowed to do full eviscerations, so we can remove the organs for the doctor. We open up the head and remove the brain. We take all the samples. We do all of the documentation, any notation that the doctors want to make. We do all of that. We also are responsible for collecting and sending out those samples for testing, whether it's toxicology or histology, which is making slides from various organs, or whether it's like if we're looking for something like COVID, which happened when we were in the pandemic, we were sending out a lot of testing for COVID. We also then are responsible for releasing all of our decedents to funeral homes. So once we have completed the investigation, completed the exam, we then work with the families to get them to a funeral home so that they can finish with the afterlife care. So that's the funeral home will handle all of the, getting them dressed and having the funeral and the services and a cremation. Any of that stuff will happen with the funeral home. So we release them to the funeral home. And then obviously above and beyond, we are responsible for maintaining a clean and orderly area in our morgue area and our processing area. So with our scene and hospital removals, I actually just went to a scene, which is why normally I would be dressed in scrubs for autopsies, but I am currently in my scene removal attire because I went to a scene. We respond to the scene with the deputies. We go in with our gurney and the body bag or whatever we need to remove the decedent, while the deputy is responsible for taking photos at the scene to document what they are seeing. We are responsible for assisting them and manipulating the decedent so they can get like back photos, because depending on which orientation the decedent is, we would need to manipulate them some. So we'll get back photos. For the one that I went to earlier, he has a fairly significant history of natural disease. So even though we're bringing him here, he doesn't necessarily need an exam. We're looking for a doctor that might be willing to sign a death certificate, because in the end, what we're really producing is the death certificate. So if we go through all the investigation and we find that he doesn't have a doctor, we will submit him for an exam. Whether or not, what kind of exam will depend on what kind of investigation that our deputy did. So that was what I just came from. We can also go to, like I said, hospitals. We go there by ourselves. And then, wherever a decedent is. So I was just talking to one of my coworkers about, scene removals. That sounds so easy. We go out to a scene, we remove the decedent, and we bring them back. But I've realized in the time that I have been here that every scene is different, and every scene provides various issues that we have to problem solve and, deal with the logistics and all that kind of stuff. So I'm constantly going through and figuring out, how to maneuver around whatever scene we're in, whether it's a layout of a residence. So I've been to houses where there have been just small little walkways where I've had to walk through, and that's been, rather difficult to get somebody out of something like that. Or if it's an outdoor scene, what kind of terrain we're on. Like railroad tracks, we have a lot of railroad tracks in Sacramento County, and they have all of those rocks down the side, and the gurney does not like rocks. So we're constantly trying to troubleshoot as we're going. So it's very interesting. It's never the same. That's part of what I love about this job, is that no 2 days are ever the same. And I keep thinking maybe I've seen everything, and then something new happens. So that's pretty interesting. So then we go on to processing the decedent. Like I said, we get all the stats, we document the clothes and the property. We also, for all of our decedents that come into our care, we want to identify them. And that's going to be forensically. We want to identify them forensically. So we're going to either do fingerprints, dental identification, or DNA. I don't know if anybody has seen in the news where a place has done like circumstantial identification, or the family has looked and said, yes, that's our loved one. The problem with that is that in death, we don't always look the same that we did as we were alive. And so it's hard to really identify somebody that way. And as much as a loved one wants to say that they can do that, it's almost the grief and everything that's happening, it's almost impossible. So we want to make sure that there are no mistakes. We want to make sure that we are identifying everybody properly and correctly so that we don't add to any of the trauma that's happening already in this situation. So like I said, fingerprints, dental, or DNA, depending on what kind of scenario we're in. We also take photographs of everybody, so identification photographs, to document all of everything we're seeing. Documentation is very, very important. And then we can, so in the fingerprints, we can either do a live scan, which is the digital, or we can do ink printing, which is what you kind of see in like the old kind of like old time like movies and stuff like that, where they roll the ink and they like put it on paper. We can also do, if somebody is mummified, because the decedent, the body will go through changes over time, and there can be drying of the digits. And so we can do what's called casting, which is using a silicone material that we can spread over the fingerprint, and it goes into all of the grooves that we can't get into with ink, and then pull a fingerprint that way. So we have various ways of doing that. And then we can also take x-rays. So depending on what kind of case it is, we have, if it's something like a homicide and we need to determine if there's a projectile, we can take x-rays. So we all are able to take x-rays. Then once we're done with the processing part, we then do the exam. We assist the pathologist with the exam. So like I said, depending on what kind of case it is, we can do a variety of different types of exams. We have 3 specific. The first one is an external exam, where the doctor looks at everything on the outside, documents any trauma, any obvious external disease that they can see, any kind of defects or anything like that. And then all of our specimens are taken from the outside. These are happening for cases that have a fairly significant documentation of natural disease. So we don't need to necessarily fully open them up if they have a very well documented like heart history, or something like really significant trauma from like a car accident that's not going to go to court. We can also do something like an external because it's very obvious what is going on. We have what we call a partial exam, which is where only a section of something is opened. So like if there's an elderly person that we get in and they have a significant history, natural history, but they also have a history of falling down and injuring themselves in falls. So now the question is, did they have a natural event and it caused their death, or did they fall and now that trauma caused their death? So we can open up like their head and see if there's any kind of bleeding. And then that really, it can dictate which way it goes. So we can do that. Then the other final type that we do is the full autopsy, where we do the full Y incision, remove all of the organs. The doctor sections, cuts into all those organs, looking specifically for any type of disease, any type of trauma. And we take all the specimens from inside. And then once we're through and into those types of exams, we, as CTs, we do a lot of the photography. So we're documenting any trauma that we're seeing, any scars, marks, any kind of stuff like that. We take all of those photos. Once the pathologist has finished with all of the external documentation, we begin the evisceration. So we can do a variety of types of eviscerations. You have like Virchow's method. It's whether or not you remove each organ individually or you take them out in block. We take samples, like I talked about, the toxicology, microbiology, so like looking for flu or influenza or COVID, like that kind of stuff, or histology, which is the sections of organs to look under the microscope. We also take internal photos of anything that the doctor has seen that might be a cause of death. Like if they find a clot in the pulmonary artery, that would be a pulmonary embolism, and that would be a very significant finding for cause of death. And then finally, we sew up any of the incisions that we make, and we clean and restock for the next autopsy. And then finally, I talked about releasing the decedents to funeral homes. So we only release once we have identified them forensically. We are responsible for double checking that the correct next of kin signs, which is a really big deal, because when people are going through a really difficult time and there's grief and there's anger involved, sometimes families don't always get along. And I have seen where there are two parents who may or may not still be together, who cannot agree on what to do with their child. And we need them to agree because one parent is not more responsible than the other. So while it seems unnecessary, we do need to have what we deem a majority of next of kin sign for the same, what they wish to do for the same thing. So if there are 4 siblings, we need 3 of them, because 2 and 2, they can argue forever and we won't ever get anywhere. So we're responsible for making sure that all of the correct people are signing and that they are all on the correct forms and all that kind of stuff. So there's a fair amount of legal issues that come up for releasing. We also collect the fees at the time that we release, and we make sure that all of the paperwork is correct. It is very important that we not only do this all correctly, but we do this with respect and dignity, because like Sam said, it's really important. Even though they've passed away, they are still a human that, requires that we need to be caring for all the way through. And part of what I love about this job is we get to care for the deceased, but we also, in a way, then care for their families and their loved ones, because we're giving them the answers that they may not have. They may not know what happened. So we're giving them closure. We're also somewhat part of the legal system. So when we have like homicides that come through, we're the ones that are responsible for taking the evidence that will eventually go to court. So we are responsible for providing justice as well sometimes, and really just being a part of and taking care of the county as a whole as kind of like a public health service. Because in, say, like at the time of COVID, we were responsible for determining how many of our decedents came through and actually had the disease. And that was the numbers that went to the public health department that then got published. So there's a lot of things that happen behind the scenes that are really pretty cool, that help out the community as a whole, which is part of the reason why I love what we do. And then also that we help out with individuals and individual families. So it goes from a wide, kind of like a wide angle lens all the way down to one individual. And I really enjoy pretty much every aspect of what we do. And yeah, so that's kind of a day in the life of a coroner technician. I know there's probably questions.
we got some questions in the chat.
Okay. Do I ever feel unnerved or sad seeing so many dead bodies? And what is the most interesting case I have worked? So yeah, working around decedents can really create burnout. That's one of the things that happens a lot in our field. So we do a lot of stuff. We make sure that everybody talks to everybody. We provide resources for everybody in case they're really feeling upset. If there's a really, really rough case, there have been some pretty bad cases where they've really affected people emotionally. We make sure that we give them time. We also have we have a comfort dog that comes sometimes, and we get to just cuddle with a dog just to, let out that emotions. But I also believe that looking at it kind of more of a scientific background versus like, I don't look at everybody and think about their life story and the people they left behind and their loved ones, because that can really cause me emotionally to burn out. What I look at it as, this is a problem that we are attempting to solve. We're trying to find the problem, the solution to this problem, and give that family the closure that they need to be able to move on. And if I look at it like this is, what's the answer to this riddle, then I can approach it in a little bit more of a detached manner versus seeing everybody as a sister and a mother and a father, and like that kind of stuff can get really hard. One of the most interesting cases that I worked on was we had a case where some construction was happening in Natomas area, and they were digging up to start building buildings, and they found what turned out to be bones. And so they started bringing us very large bags of dirt, and I got to go through and find all of the parts of this woman and put her back together. And we eventually identified her, and they arrested and convicted her ex-boyfriend of the murder. And it was because of what we found during the exam and identifying her that they were able to go through with that. And I thought that was really interesting, that even though he got away with it for like 2 years, it caught up with him in the end, because she was found and she was able to tell us what happened, essentially. Okay, what inspired me to become a coroner technician? So I started here when I was an undergrad in college. I was looking for internships that I thought would be interesting. I wanted to go into the medical field in some capacity. So I heard that there was an internship where I could assist with autopsies. And I've always loved forensics, and I've always loved just anything to do with puzzles and problem solving. So I thought that would be really interesting. I started this internship at the exact same time I started an internship at a hospital, a local hospital, in the emergency room. And it did not take me very long at all to realize that I absolutely loved this type of work specifically, and that this is what I wanted to be doing. And so I stopped as soon as I was done with the hospital internship. I completely changed gears and applied for the coroner's office, and I've been here ever since. Are there ever days where there are no cases to work on? Sacramento County is a very large county. I didn't realize how big it was until I got up here and we started driving around. We go all the way from Folsom way up to the top, all the way down. We actually have a very small area all the way down to the Delta. So I have driven for like an hour and a half to go get somebody one way and then had to come back. It's very rare that we don't have cases. It does happen every once in a while, but last week was incredibly busy. And so that's usually what it goes towards is we're usually trying to figure out how to clear our schedule rather than trying to figure out busy work. But we do have some days that are slower than others. It just depends. But yeah, very rare are there no cases at all. Average salary as a CT. So I think we start around 56,000 a year, and then it can go up depending on. So we have a couple of different levels. I'm a senior CT. We have a supervising CT, so we can make it through those levels. I'm not exactly sure what we top out at, but the county is really good. What's really cool about working for the county is that I have really good medical benefits and, mental health benefits that are really, really good because of what we do. So it's very important that they provide us with these things, and the county is really good about providing that. So it's not just about the salary, it's about the different benefits that come with it. So, and the retirement, the county is really an awesome place to work for a fairly long period of time. And then the schooling journey to become a CT. So for schooling, on the application, when we have people who apply to be CTs, the actual requirement is 30 units of college in a science or criminal justice type background. So it's not a lot. When I first started, it was with a private company that contracted, and really they only wanted us to have taken like anatomy and physiology in college. That being said, a lot of our CTs are very well educated, very highly educated. I have my bachelor's in microbiology, but I also have a master's in forensic science and an MBA. So the county is really interested in people bettering themselves, so they'll pay for some of the schooling that we go to. And so a lot of our CTs have their base education is they already have their bachelor's. So it's pretty cool. And then we get to work with doctors who are obviously MDs and have gone through medical school. And so we learn a lot more through the job. And so it's harder. I run the internship program here, and it's hard because I have people say, well, I have no experience. And I'm like, well, you can't get any experience until you come in with our internship, because there is no other experience to get. So really, the schooling isn't as big a part as the learning on the job is. So yeah. Are homicide forensics like they are on TV? So it's fun to watch those shows. They are very entertaining, but it's also kind of stressful when like those shows, like they will do a test and they'll get the results in like 2 minutes, and they have an answer for the family. And so now the families are like, why don't you have an answer for me? Because that test takes like 2 months to complete, and we won't know the answer until like we hear back from the lab. So yeah, it's funny. I understand why they do it. Obviously, they can't have the TV show go on for 3 months of you not knowing what's happening, but it's also like a condensed timeline. So yes, a lot of those things that they do, we also do. A lot of those things, they have the correct answer, but it's just on a very condensed timeline. So yeah, we collect that evidence, and then we have to send it out for testing. And then that testing could take a fair amount of time. I know we just sent out DNA. We're trying to identify somebody. We get people in who are unidentified. And like I said, where we have to run DNA. The DOJ runs our DNA, and they take upwards of 6 months to run that DNA. That's 6 months that somebody doesn't know if that person in our morgue is their loved one or not, which can be very stressful. And I wish that it went as fast as the TVs make it seem. And maybe we'll get there one day. Maybe it'll get faster. But currently, it is not nearly that fast. Our coroners, law enforcement. Our deputy coroners are what's called post-certified. So they do have to go through training, and they do carry weapons. They, however, are not going to be arresting anybody. They're not, that's not the kind of enforcement that they do. They are mostly the investigation side of law enforcement, but we do have to go through that kind of background check to be a deputy. The good thing about the CTs is that we are civilians, so we don't have to become post-certified. We do not carry, we're pretty much always with our deputies, so we're protected. And if the deputies aren't there, we generally have law enforcement like police or sheriff with us, so we're very well protected. But yeah, our deputies are post-certified. Last question, probably, were you ever scared of seeing blood or traumatic things before becoming a CT? I was not. That never really bothered me. And it's actually when I viewed my first autopsy that I knew for a fact that this is what I wanted to do, because it absolutely did not affect me in any way. But I also know that it can affect people. So especially with my interns, when I have people starting the internship, I have them view 4 different times, because it may not hit them the first time that this is really emotional for them. It may not even hit them the second time that it's super emotional for them, or that they cannot handle the sights or the smells or the sounds, because there's a lot of sounds that happen during an autopsy. So I make sure that everybody that comes through here and is interested in doing this job, that they really understand what it entails, because it is not meant for everybody. And I understand that. But for me, I absolutely knew right away that I was meant to do this.
All right. Well, thank you so much. We appreciate your time. This is always one of my favorites. I'm so glad we had all these questions. And thank you for sharing part of your morning with us. Everyone, please thank Shannon.
Oh, thank you guys for having me. I always love doing this.
All right. Well, that is it for today. Our winner of the gift card is Rithik Sangani. I will go ahead and send you a gift card, and we'll see you at 10 a.m. tomorrow. Have a good afternoon, everyone.